Hello, everyone, and welcome to a session with OrthoNinja Academy. Today's topic is compartment syndromes, and I hope you're going to enjoy this session. I'm Raheel Shariff. I'm an orthopedic consultant, previously at Manchester University Hospital and currently in Jeddah. I've got with me Amer Shoaib, a friend and a colleague. Amer, hi.
Hi, Raheel. Hi, everybody. Welcome to today's webinar. It's a controversial subject, compartment syndrome, and I've got to say that it's still something that makes me feel very nervous when my resident sort of says that they're worried about someone with compartment syndrome. So there's a lot of controversy, a lot for us to talk about, and hopefully everyone will be able to take something away with them that they'll find useful in their practice.
I think controversial.
So, shall we start off by looking at a case?
Sure.
So we've got a case, and we're going to have some polls as we normally do. So the whole point of this is that you can take part in the poll, and we don't know who's voted for whichever option. So there's no pressure, there's no humiliation, there's no embarrassment. You just vote, see what you think, and then hopefully you'll be able to learn something from the result and get an idea about what everyone else is thinking as well. So this is our first case. It's a 23-year-old man. He's been to the gym and he's using free weights, and he's unfortunately dropped one of the weights onto his foot. And you can see in that clinical picture, his foot's looking a bit red, a bit swollen, and there is a bit of bruising around the toes as well. So let's move on to the next slide. And he's got multiple fractures of the phalanges, and he's in a lot of pain, so much pain that it's bringing him to tears. And obviously it's something that's very concerning because you're worried that he's in so much pain. It's disproportionate to the injuries that he appears to have. So your resident says, I'm worried about compartment syndrome. Can you get compartment syndrome in your foot?
So you've got a poll going. We'd like you to answer that question. When Amer started off by saying that it's a controversial topic, that's quite an understatement, because when we were off air, a couple of minutes before we started, we realized how divergent we are in our management of these cases. I'd like to think I'm old school. I'm not sure about Amer. So Amer, do you think compartment syndrome exists in the foot?
Absolutely, absolutely. So if you think about what compartment syndrome is, it's pressure, increased pressure in an osteofascial compartment, and the foot, like everywhere else in the body, has got osteofascial compartments. So I think yes, it does exist. Do you agree that it exists?
I do agree it exists, but what we do about it is a different question altogether.
Yeah. Okay.
Yeah.
So
let's get to that.
Let's move on. So I think everyone's in agreement. So 100% of people who voted have said that they believe that compartment syndrome exists in the foot. Okay. So let's move on to the next picture. So now this is where we're going to get controversial. So the picture show, you can see his X-ray. He's got fractures in the phalanges, but he's got compartment syndrome in his foot. So should you decompress the compartments? So I'd like to see how people vote, because even amongst ourselves, we can't agree. So there's no right or wrong answer. It's just a question of your own personal opinion, and it'll be interesting to see what people think.
Seems like you're pushing your Trumpian theories to your registrars, Mr. Shoaib. We've got a majority saying they want to decompress.
Well, yeah, there's a good argument to say they're right. What about your fake news that you don't want to decompress?
Right. So I know Amer. We go a long way back, and Amer is very dedicated to what he does. The problem now, Amer, is when you go and open that foot up, how are you going to close it? So let's see what the audience are saying. 73% say that they want to decompress the foot. 27%, a third, are the minorities seem to suggest they don't want to. The issue here is that once you open up that and flay open that foot, you're going to have problems closing it. 50% of patients have neurological problems, and 65% of patients have wound complications, and almost 40% require plastics input. So the argument for not opening that foot is that, let's say, for example, the patient develops compartment syndrome and then has, what's the worst that's going to happen? He's going to end up with claw toes. So it's easier to deal with claw toes and straighten them out than put him through that morbidity of flaying open that foot. So that's the argument for not opening that foot up. Let's see what Mr. Shoaib's comeback there is.
Right. Well, I would say that I agree with a lot of what you've said. If there were fractures that were exposed, that would be exposed by performing a fasciotomy, and in order to perform fasciotomies, you need to make dorsal incisions to decompress the interossei. And so, if there were fractures underlying there, then I'd be thinking, well, if I perform fasciotomies, then I'm going to be leaving that wound open. There's a risk, or it's 100% chance of it being colonized, and that means that there's a substantial risk that it might get infected. And especially if I put metalwork in to fix the underlying fractures, then I'd be concerned. But because it's a soft tissue injury, yes, you're right that performing fasciotomies could result in neurological symptoms afterwards, but equally, the compartment syndrome itself, because of that increased pressure, some of the first structures that are affected by compartment syndrome are the nerves. So there is actually a risk as well of, I would say a higher risk if you don't decompress, of damage to the nerves, and that could in itself cause morbidity for the patient in the future. So, but with these phalangeal fractures, I can still wire these fractures, and I'm not exposing the fractures through the fasciotomy wounds. So that's my argument, that I can decompress without causing any exposure of any fractures, and I can keep the foot elevated. And yes, it might need a split skin graft later on, but I may actually be able to close these wounds once this swelling has gone down, and I don't have the morbidity in the future from the nerves or from the clawing of the toes. So it's a question of taking a choice about what morbidity you want after a condition like this. So for this particular problem, I'm going to say I would decompress, because I think that there's no additional, there's less additional risk from performing that procedure. But it's one of these things where there's no right or wrong answer, and everybody's got opinions, and I think that we're going to agree to disagree on this one.
I think you're absolutely right there, Amer. So you can see there's a lot of controversy already. We're less than 10 minutes into this topic. I'll let you carry on.
Okay, so we're going to change the situation a bit. So I'm going to change the X-ray. So before, the fractures were in the phalanges. Now the fractures are in the metatarsals. So the question I'd like you to answer is, should I decompress the compartment now?
So
there are obviously
while they're answering the question, let's find out how much more we differ. How many compartments in the foot, Amer?
I would say there are 10. So we've got the interossei.
I'm not going to put you on the spot and ask you to name the compartments. So you're saying 10, right? So see, this is the problem for our audience. Some surgeons think they're 10, some think there is that elusive 11th, some think there are 9. So as a consultant body,
people thought there were 4.
yeah, exactly, there were 4 when
Yeah.
way back in time. So as a professional body, when we can't seem to agree on how many compartments in the foot, how are we going to successfully decompress all those compartments? That's my point.
Yeah, I would say that if you can decompress compartments where there are nerves which are at risk, then that for me would be a valid sort of way of making a choice.
So I'm just, I'm just playing devil's advocate here.
Yeah,
or pushing
absolutely.
against.
And I mean, I suppose the question is, does it make a difference whether there are 9 or 10 or 11?
Absolutely.
Okay,
so let's see what the answer to these questions has been. 60% say that they would not decompress because there are metatarsal fractures and you would potentially convert this into an open fracture. 40% say they would. So still a fair split there. But I think the take-home message we're trying to give you is that if there is a fracture in the foot and you're going to be decompressing, you're probably going to end up creating more morbidity and complications, converting it into an open fracture. So you'd rather just bite the bullet, let that patient develop compartment syndrome and deal with the sequelae, because it's much easier to do so. Are we in agreement there?
Absolutely, I agree with you there, because if you've got claw toes, which is sort of intrinsic minus foot, is sort of the inevitable consequence of compartment syndrome of the foot. There aren't that many muscles. There are only the sort of the intrinsic muscles, flexor hallucis brevis and flexor digitorum brevis, and the extensor digitorum longus and brevis. So there are not many muscle bellies to die, but they will cause clawing of the toes, and that's something that can be dealt with at a future date. And for me, if there are fractures underlying, I don't really want to risk that excess mobility from converting into open fractures. So I agree with you on that one. At least there's something we've found some common ground on.
It's just taken us 12 minutes, but we've got there. Okay,
shall we move on to the next slide then? So the next question, I mean, on the pictures you can see that there's this is how I've performed a decompression in the past. And the question is it worth measuring compartment pressures? Because there's a monitor, and should we use that monitor to measure the compartment pressures? And is that helpful for making a decision? So the question is really, should I measure the compartment pressures? Is that going to really make a big difference to how we manage the patient?
So this is something we're going to tease a little more out during our talk about the use of a compartment pressure monitor. Let's see what the audience says. Over 90% say that they wouldn't use a compartment pressure monitoring device.
Do you agree with them?
Yes, I agree with them. I think it's essentially a clinical diagnosis, although pressure monitoring device does have its role to play in certain instances, and we can discuss that later through the course of this discussion. But from a practical point of view and from real life experience, I think a lot of us wouldn't necessarily use a pressure monitoring system. I don't use it in the foot anyway, because I never decompress the foot, but I put that question to you.
Yeah, so I agree with you on this point, especially the foot. I wouldn't be measuring the compartment pressures. It would be a clinical diagnosis. Elsewhere, there's a role, but there are logistical problems with being able to use compartment pressure monitoring effectively. And I know you're going to be talking about this later, but there are ways of measuring compartment pressure which are helpful, and there are ways which may not be as helpful as you would hope. And unless you are going to be able to measure them continuously, it's really not very helpful. So I wouldn't use compartment pressures, especially in the foot, to make a decision about decompression. And in my normal day-to-day clinical practice, I wouldn't be using pressures for anywhere, really.
So now that we know that you do decompress a foot, Amer, what are the top 2 tips you would give us about the diagnosis, the clinical signs in the foot? We're not talking of limbs here, the foot. Is it just purely the swelling that makes you say, oops, that looks like a compartment syndrome, I'm going to go and flay that open? Or is there something more to it?
I think that basically swelling on its own is not an indicator for compartment syndrome, because you see any patient with a Lisfranc injury, their foot is swollen like a balloon. So you can't really assume that if you've got a very swollen foot, that means that they've got compartment syndrome. Like other areas of the body, it's all down to pain, and you've got to assess their pain and their reaction to the response to opiate analgesia, and that is really what's going to give you the diagnosis. If they fail to respond to opiates and splinting with a back slab and elevation, then you've got to be concerned that the patient's pain is out of proportion and there's something more going on than just a simple fracture.
Okay. So that's the end of that case, isn't it?
That's right, yes.
Right. What we're going to do is dive into a brief talk on compartment syndrome, specifically looking at a few key topics. So as you found, this is something which is fairly box standard. It's as an orthopedic surgeon, we understand we've got to go and decompress a compartment syndrome. There's no 2 ways about it. But when it actually comes down to the nitty-gritty, you do find a lot of umming and ahhing about certain cases. Is this a compartment syndrome? Is it just swelling? So we've got to have a very clear picture in our mind's eye as to what the algorithm is in a diagnosis of a patient with compartment syndrome. What is the pathophysiology? What is the etiology causing this? And what we do to go about dealing with it once we've picked it up. So that's what we're going to focus on in this talk. So here's a question for all of you to start off with. What is the risk of compartment syndrome when you compare open fractures with closed fractures? The options you've got are open fractures have a 5-fold increased risk compared to closed. Closed fractures have a 5-fold increased risk compared to open, or both have the same risk. So let's give the audience a moment to answer that. Amer, what are your thoughts?
Well, it's quite interesting. We had a discussion about this when we had our first talk on open fractures. And I think we said that open fractures have an increased risk of compartment syndrome because it's a higher and usually higher energy injury. So that's my take on it.
Absolutely. I think the audience seems to be a bit divided between both have the same risk and open fractures have a higher risk. The right answer to that is, as you rightly said, open fractures have a much higher incidence of compartment syndrome. It's quite counterintuitive because you think that an open fracture, it has decompressed through that wound, but actually the wounds are quite small and the energy imparted in that fracture site is significant, causing a lot more extravasation and bleeding, which gives rise to compartment syndrome. So the incidence of compartment syndrome in a closed fracture is 1%, whilst in open fractures it's 6%. So it's a significantly increased risk. Okay, so what is compartment syndrome? Let's get these nitty-gritties out of the way. Essentially, it's an elevated amount of pressure within a closed myofascial or an osteofacial compartment, wherein the amount of blood coming into that compartment is reduced because there is increased intracompartment pressure, and that gives rise to ischemia and necrosis of the muscle. And what we've found is typically that pressure threshold is 30 millimeters of mercury. So if your intracompartmental pressure goes above 30 millimeters of mercury, then you're bound to end up with muscle ischemia and necrosis. So some key buzzwords and definitions we need to know of. Tissue perfusion pressure is the diastolic blood pressure minus the intracompartmental pressure. And that's essentially the pressure through which the blood perfuses within the tissues. And if we look at the pathophysiology, if you have a direct injury, you end up with extravasation or an arterial bleed, which causes increased edema in that compartment. That gives rise to an increased compartmental pressure, which reduces the blood flow and ischemia. Now, a fasciotomy breaks that cycle, and if you don't do a fasciotomy, you end up with the usual classic 5 Ps. So let's deep dive a little more into that pathophysiological diagram. So here we've got an artery, which breaks down into arterioles. You've got capillaries, venules, and veins. So that's your tree. Now, what tends to happen in a closed compartment is that if you have an injury, there is edema from extravasation, and that starts compressing the venules. That in turn causes the stasis within that compartment. There's an increased compartmental pressure because there's those venules which are collapsible are beginning to sort of close because there's fluid in the extracellular fluid which is closing down on those venules. Now, the blood, as we know, flows through the arteries into the arterioles, but because there is that stasis, that gives rise to ischemia, and that's what gives rise to the compartment syndrome. So in a very pictorial sense, that essentially is what happens. And this is an example which Amer uses, and it's a very nice one to highlight. So think of it like a tire with the outer lining of the tire and then the inner tube, which is the contents of the compartment. Now, if you start blowing up pressure into that inner tube, you're increasing the pressure within that compartment. At some point, that inner tube will go and hit that outer rubber lining. And that's the threshold at which point your compartment syndrome occurs, because there's no further expansion space for it, and you end up with compartment syndrome. So as we said, it's a vicious cycle. Increased bleeding, increased soft tissue injury gives rise to edema, which increases your compartment pressure. That in turn causes the ischemia. Why does it occur? So the two factors. One, you've either got a decreased compartment size or you've got an increased content within your compartments. It's as simple as that. That's what's going to increase your pressure. You've lowered your compartment size or you've increased the amount of contents within that finite space. What are the examples of a reduced compartment size? You've got constrictive dressings. You know, when you've got tight dressings around, circumferential dressings around limb. You've got splints and casts, which are put on very tight. And you've got external sustained pressure, maybe a crush injury like that dumbbell on that foot, or sustained pressure from a log of wood which has fallen on the patient and the patient's been trapped under that. What increases the content within the compartment? So trauma with edema, vascular injuries with bleeding. Interestingly, insect and snake bites can give rise to a significant amount of exudation of fluid within a compartment and give rise to compartment syndrome. Intravenous cannulation and extravasation of fluid, or hypertrophy of muscle, which gives rise to your classic chronic exertional compartment syndrome. So any of these can contribute to your compartment syndrome. And how do we diagnose it? So you've got to have your risk factors in mind. Bear in mind, the odds of a man developing a compartment syndrome are much higher than a lady, 10:1. 50% of compartment syndromes tend to occur in tibial fractures. So if you've got to pick a bone, we all know tibial fractures are a high risk category. And we've discussed the open versus closed fractures. The risk of compartment syndrome is 6 to 11% in forearm fractures. And particularly in the pediatric age group with supracondylar fractures, if you flex the elbow, you've got a much higher chance of developing compartment syndrome when you put a patient in a back slab. So it's probably better to consider putting a patient in a semi-extended back slab than a full in a flexed posture. So male to female ratio is 10:1 for acute compartment syndromes, but when it comes to chronic exertional compartment syndromes, sex doesn't really play a role. So here's a question for all of us. What is the earliest sign in diagnosing a compartment syndrome? Is it increased swelling of the limb, increased girth within the limb, pain on passive touch, or loss of two-point discrimination? So we're going to give you a moment to answer that. Amer, what are your thoughts?
Well, to be honest, I'm wavering. I think swelling isn't necessarily important for compartment syndrome because, you know, especially like the deep compartment of the lower leg, you can't even see it, so you can't tell when there's any swelling there. Pain on passive stretch is certainly very important, and you know, I'd be using that as one of my indicators for diagnosing compartment syndrome. I also know that, you know, in some instances, loss of nerve function can be caused by compartment syndrome, and that can be relatively early. But I think I'm going to go with most of the audience and talk and say pain on passive stretch, but I'm not sure if I'm right on that.
So it's interesting. 86% of our audience seems to think it's pain on passive stretch, and that makes sense for us as orthopedic surgeons, because that's what is drilled into us from a very early age in our training, that pain on passive stretch, aka compartment syndrome, which is true. That's the sign we tend to use. But actually, the loss of 2-point discrimination is the earliest sign in picking up a compartment syndrome. So just a nugget there for everyone. So we've got this, we've discussed this, 5 Ps: pain, pallor, paresthesia, pulselessness, and paralysis. We've lost the war before it's even begun, essentially, if we're looking for those signs. So none of those actually are what we're looking for. We're going to go through what the main key signs are: pain, pain, and more pain. Yeah, and the pain, as we've typically described it, as we all know, is out of proportion to the mechanism of injury. There is increased need for analgesics and opiates, and it doesn't really dull the pain. And the passive stretch we've discussed. 2-point light touch is the most sensitive early sign, and the swelling, which is described as typically rock hard or woody, but you don't really see that in clinical practice. You tend to see firm sort of compartment. A word of caution in the young: don't rely on those typical adult signs. We talk about 3 A's in young children: anxiety, and increased analgesic use, and agitation, because they can't really explain their symptoms very, very well to us. So if we've got a suspicion, look for the 3 A's in children. So here's a on-the-shop floor, step-by-step algorithm. A lot of us are familiar with it, but I'd make no apologies for brushing up once again on this. We've got to have a high index of suspicion. Now, once we've been called in, asked to see a possible compartment syndrome, you want to cut all those dressings and that splint down to skin. Because as Amer rightly pointed out, that there's an increased compartment pressure just by the circumferential dressings. In fact, there are studies which have shown that 40% of increase in compartment pressure occurs with a circumferential dressing. So once we relieve that, that makes a huge difference, and the compartment pressure can drop. When we've done that, we assess for pain on passive stretch, but remember from now on to consider the 2-point light touch discrimination. And if these signs are positive, then yes, we've got compartment syndrome. If they're negative, then what we do, as this was pointed out earlier in the talk, was to elevate the limb and give them strong analgesia. Make a note of the time, come back in about 20 minutes or 30 minutes, reassess the limb. If the patient has pain and passive stretch, yes, compartment. If not, then it's unlikely to be so. So that's the dummies algorithm, which I even practice to date in diagnosing a compartment syndrome. Do you do anything different, Amer?
I'm doing one thing that I do slightly differently, which is elevation. Now, you mentioned about the diastolic blood pressure and how important that is. Now, if we elevate a limb, we lower the blood pressure within that limb. So actually, the pressure in the compartment may not change, but if we elevate, I'd be worried that we're decreasing the diastolic pressure within that limb. And so actually, it's making the risk of compartment syndrome becoming clinically significant higher. So I tend to keep the limb at the same level as the rest of the body rather than elevating it or keeping it dependent. But that's it. Otherwise, I do everything exactly the same as you.
Okay, that's a fair point, because you're trying to reduce the, well, essentially we end up reducing the diastolic pressure by elevating the limb. So the difference between the diastolic and the intracompartmental pressure tends to deviate, and you're saying it could compound compartment syndrome. It's a dogma we've all grown up with, that when there is swelling, elevate the limb. So yes, fair point there. Omer has asked a question: which is earliest? Omer, I hope that's the answer has been given. It's 2-point discrimination. I suspect that was your question. Ayman's asking us another question: if the patient has compartment syndrome in the foot and not responding to narcotics, is it okay to leave the patient in pain? Yes, I agree, but I think Amer has other thoughts. He would go ahead and decompress that.
Well, I think it depends. Yeah, if I was in the situation where there are fractures underneath, and the patient's in pain, then especially if opiates are not helping, then what I would do is I would just block the popliteal nerve, and just basically mask the pain, so that the patient can get through that sort of period of excruciating pain without having to without having to take large doses of opiates. But I've got my sort of logic for how I'll go about with decision making for compartment syndrome, and it would still be dependent on whether I'm going to expose bone underneath. It's interesting that when we look at the tibia, it's slightly different, but yeah.
So I think it's a very important point which is being made here. We're focusing, when you talk about the foot, Amer is talking about blocking the pain with a nerve block, because if it comes higher up in the limb, we do not use nerve blocks, as we don't want to mask the symptoms. So yes, if there is a fracture, he's decided he doesn't want to open it, come what may. He just wants to dull the patient's pain, so he's blocking giving the patient a block. Okay, so let's talk a bit about pressure monitoring, these adjuncts to diagnosis. So it's extremely important to have a very clear algorithm, as we've discussed, and you decide pretty much on your clinical diagnosis whether this patient has compartment syndrome or not. In some instances, pressure monitoring might come into its own, especially in patients who have altered consciousness or children following surgery where they have continuous pressure monitoring applied. It's controversial because more than 50% of orthopedic surgeons don't use this. This is from an American JBJS article, which had essentially sent out questionnaires to orthopedic surgeons and found that a large number don't actually use pressure monitoring. And I think that's replicated in our clinical practice as well. The principles of pressure monitoring are that ischemia occurs when the perfusion pressure is more than the capillary pressure, and that usually is a 25 millimeter or 30 millimeter threshold. And death of the muscle occurs when the diastolic pressure minus the intracompartmental pressure, when you minus the two, it's less than 30 millimeters. Excuse me. So in children, it's important, if you're going to consider pressure monitoring, not to use the diastolic pressure, because they tend to have a spuriously elevated diastolic pressure. It's not very reliable. So we need to use the mean arterial blood pressure. And remember, the distal pulses are not going to give us any additional benefit here. So we've got two methods. This is a common MCQ in the FRCS and the board exams. You've got your direct pressure method and your delta pressure method when you're examining with the pressure devices. If you stick a needle into the patient's compartment and the intracompartment pressure is more than 30 millimeters, that's compartment syndrome diagnosed. That's direct pressure method. Okay, there's no subtracting and things like that. The delta pressure method is a bit more sensitive to an extent and specific, because you're looking at the difference between the diastolic blood pressure and the compartment pressure. So we stick a needle into the patient. Let's say we get the compartment pressure to be 40 and the patient's blood pressure is 90. Then the difference between the diastolic blood pressure is 90. Then the difference 90 minus 40 is 50 millimeters. So that difference is not less than 30 millimeters of mercury. So i.e. this patient does not have compartment syndrome. That's how you work out the indirect method or the delta pressure method. So here is a picture showing you the striker has got this device which is commonly used, and some tips on if you're using these. You've got to take at least 2 or 3 measurements, and when you first stick the needle into the muscle compartment, you find sometimes that the pressure is off the charts, and that's a false reading because your needle is sometimes blocked and it tends to hit tissue, and that gives it's quite a sensitive instrument. So one way to overcome that is to just flush 1/2 ml or 1 ml of saline through the needle whilst it's in the compartment, and that tends to give you a better reading once that's been done. And you put your needle perpendicular to the long axis of that limb, you take a measurement close to the fracture and you take a measurement away from the fracture. Here is an example of the reading. It's 76 millimeters of mercury. Let's say this patient's diastolic blood pressure is 90. The difference is 14. It's less than 30 millimeters. So this patient has compartment syndrome. So I hope that's clear to everyone, that if we do monitor, this is the way we do so. Okay, which brings us to this question of continuous versus intermittent monitoring. And Amer alluded to this earlier in that case example. This is a paper from McQueen et al. In the JBJS, where they looked at 25 patients with tibial fractures and acute compartment syndrome. This was diagnosed. What they then did was they subdivided this group into those who had been monitored continuously. Their pressure was monitored continuously, and that was 13 patients. They had a mean delay from injury to fasciotomy of 16 hours with no long-term sequelae. The other group, which had been who had their pressure monitoring done intermittently, there were a total of 12 in that group, and the mean delay from injury to fasciotomy was 32 hours. So it took a lot longer to diagnose them because they were being looked at intermittently with regards to monitoring for the pressure. And 10 out of these had significant weakness, contracture, and delayed union. So the take-home message is, if you decide to monitor pressure, it's probably better to do a continuous monitoring because it's much more reliable. You pick up the compartment syndrome a lot earlier versus intermittent. Which brings us to fasciotomies. Now, it's a huge topic to cover, but we're going to go with where the odds are. The chances of us picking up a compartment syndrome is most likely in a tibia, so we're going to deep dive and focus on that. The principle is that if you decompress within 12 hours, you've got normal function restored. But beyond 12 hours, you have only an 8% chance of restoring normal function. So there's a significantly increased risk of complications if you've waited for 12 hours to decompress someone's limb. So this was another paper from the American JBJS, which looked at the long-term results following fasciotomies. And what we've got to understand is that these don't come without risk. Even if we pick up compartment syndrome early and we do a fasciotomy, you've got significant complications which can occur. 15% of these patients had rest pain. 27% had pain with exertion. Almost 50% had decreased range of movement and sensation, long-term follow-up at 7 years, and close to 40% of fasciotomy wounds will get infected. So yes, we've got to act fairly aggressively and quickly when we pick these up, but bear in mind that these do come with their host of complications. Excuse me. So here is a picture from the BOA BAPRS guidelines, which we have discussed before, and we're going to go through this once more because it's crucial. The picture on your left with the markings on the leg is the dotted green lines are the tibial border. You've got your posteromedial border of the tibia, and you've got your the tibial crest. On either side, those blue lines are the fasciotomy lines. So it's important for us to know where to make our fasciotomy incisions. Your posteromedial fasciotomy line is 1 finger breadth posterior to the posteromedial edge of the tibia. So you feel the edge of the tibia, you mark it out, and 1 finger breadth posterior to that. You don't want to go any more posterior than that, because that ends up with damaging the perforators of Boyd, which, as you can see, are marked out with those X's in that picture. Your anterolateral fasciotomy line, which is what we will use to decompress the anterior compartment and the lateral peroneal compartment, is 1.5 finger breadths from the crest of the tibia on the lateral aspect. So once you've marked those out, there was a question asked in the previous talk about how long these fasciotomy lines should be. And the answer to that is as long as it, you can never be too long. So you want to feel the crest, that flare of the proximal tibia, and right at that flare, you want to start your proximal most incision and go all the way down to the malleolar. Okay, so no one's going to criticize us for making long fasciotomy incisions, so don't be afraid to flay it open. What we will be criticized for is making them smaller than needed. So just go big. So here's an axial view. We've got our tibia and fibula in white there, and the subcutaneous border of the tibia marked out in that arrow. So let's go through step by step how we're going to decompress this. That's our posteromedial incision, which is a finger breadth behind the medial edge of the tibia, and the anterolateral incision highlighted in blue there. So let's start with decompressing the posterior and deep and superficial compartments. So once we've made that incision and it's all the way along the length of that tibia, the first structure you're going to encounter is the deep fascia to the superficial compartment, which we're going to go through. And then it's important because a lot of times we go in and do a fasciotomy, but when we've gone back for a second look, excuse me, and someone's done that fasciotomy, you tend to see that they have not actually decompressed that deep compartment. They've gone in and opened up that superficial compartment. So it's really crucial to identify that fascia between the deep and superficial compartment, which is highlighted in that bright green or yellow, and open that up. Once we open that up, we can decompress that deep compartment there, that shaded area, and the superficial compartment. So make sure that we go through that deep fascia separating the superficial and deep compartments. When it comes to the anterolateral incision to decompress the anterior and lateral compartments, when I was a young trainee, I used to struggle to actually figure out how this works. And it took me a couple of them to actually work out how this is done. So this is what, so you cut through, you make your long longitudinal incision and you come to the deep fascia of the anterior compartment. That's that line there. We go through that and we're pretty much, it's pretty easy to open up that anterior compartment. Now the trick is getting through that incision to the lateral compartment. You've got to put an Army, Navy or a deep retractor into your skin fold there and get to that intermuscular septum between the anterior and lateral compartment. You've got to identify that, and that's easier said than done. You've actively got to look for that. Once you've done that, you incise that through its length, and you can start seeing your perineal muscles sort of bulging out. So then you decompress your anterior and your lateral compartment. So we've got to make sure that all four compartments are decompressed, and that's a step-by-step approach I take in my mind when I'm doing a decompression. So this is one of Amer's patient who has had, you can see the full length of the leg has been opened up. And this is how the muscle is pretty, it sort of bulges out, as all of us have seen. Now you've got to consider what you're going to do with muscle which is dead. You're going to debride because you don't want to leave any dead tissue in there, but it's a bit of a fine balance. We'll tease this out in further during this talk with Amer. The question is, how do we close? So obviously we're not going to close the first stage, but it's your options are to put a back dressing on or to use this Roman sandal or shoelace technique. I find this very useful. Amer, do you use this? I think you do, right?
I have used it in the past, but I must say that more recently I've gone for the tactic of closing one of the wounds and then getting the plastic surgeons to split skin graft the other wound, just as a means of getting one, the wound that's going to expose the bone most. I want to close that quickly.
So you primarily close one of the wounds?
Yes.
Okay.
But
so,
only, of course, if there's enough soft tissue laxity to allow that to happen.
Sure. So that's an absolutely fair way of doing that, because you want to just try to minimize the amount of morbidity this patient is going to have with possible skin grafts in the future. Word of caution, because if your compartment's not looking very healthy, you're obviously going to come back and look at it for a second look. So it may not be, I'm sure you don't close in those instances, correct?
No, absolutely.
Yeah. So this is where you use these vascular elastic loops or bands, and you just sort of string them along and keep using staples to close. It works really well. And you can see, as you can see here, this wound on the right-hand side has a fairly wide diameter. And as you keep closing, it can narrow, you can sort of use tension to close this down. Vac dressings work equally well. Quick word on chronic exertional compartment syndrome before we end. You've got, this is quite a tricky one because you've got to use pressure monitoring to identify it. And it is diagnosed by one of the following findings. If you've got a pre-exercise pressure of 15 millimeters or greater, or you've got a 1 minute post-exercise pressure of 30 millimeters or greater, or a 5 minute post-exercise pressure of 20 minutes or greater. Now, it's important to diagnose this with pressure monitoring, especially if you're going to go down the route of decompressing these patients, because you need to have some medical legal backing for this before we go in. Do you do this any different, Amer?
Yeah, obviously the difficulty is getting the patients to exercise enough. So in the end, what happens is I get the patients running up and down the stairs outside the theatre block, and then I get them to come into theatre. And it sounds quite comical, but they come into theatre and then I measure their pressures. And then if their pressures are high, then they go on to have surgery.
Yeah. We've got another question from Omer. How to deal with a diabetic patient. Amer, do you want to take this one?
All right, well, that is
not
a difficult
chronic,
question.
Exertional, it's for the compartment syndromes per se, I take it.
Right. Essentially, when you've got somebody who's diabetic, and I take it almost talking about someone with a glove and stocking type distribution of neuropathy, they're going to be affected in their foot first by the neuropathy. It's not often that you actually have someone's neuropathy extending up to the knee level. So it's a notional problem, but in reality, if someone's got compartment syndrome, they will feel it, even if they are diabetic and they've got some neuropathy as a complication of the diabetes. So I think it's not really an issue, but it's an interesting question.
I hope that's answered your question. Feel free to follow up with any further questions if you've got them, Omar. The other possibility you've got to consider is infection, but I think you've got to open up the compartment because rhabdomyolysis with chronic renal failure can have its own complications. Okay, so with regards exertional compartment syndrome, actually the outcomes are very good. The evidence and literature suggests 87% to 100% report full return to exercise with no pain. And these are, I tend to do with two small mini incisions, and it's usually the anterior anterolateral compartments which are compromised, not the posterior. So one 5 centimeter incision at the top end of the leg and one 5 centimeter incision at the bottom. And I tend to use a scissor to get the two ends to meet through that. Do you do anything different, Amer?
What I tend to do, because it's the exertional compartment syndrome is affecting the area of the limb where there's muscle belly. I do it in a very similar way to the way you do it. But a tip that I can give people is that go to your general surgical theatre and borrow one of their laparoscopic scissors. Laparoscopic scissors, they're that long, and you can actually. And the other thing that you can borrow is a rigid bronchoscope. So what I do is I pass the rigid bronchoscope down a tunnel, and then I can use the laparoscopic scissors to cut the fascia under direct vision. I find it may not be any more effective, but I find it very satisfying as an operation to be able to see exactly what I'm doing.
There's a surgical tip and trick paper there, myoscopic release for chronic exertional compartment syndrome. Okay, thanks, Amer. Okay, quick summary. So clinical examination is key. Remember the 2-point light touch discrimination. When in doubt, decompress. There's no point umming and ahhing. If we've got a suspicion, we just go ahead and decompress, as we all know. An important point to note is that once we've decompressed, we've got to monitor the urine output and the renal function, which is something as surgeons we can sometimes take our eye off. And it's very important from a medical legal perspective to document clearly when we see a fracture that this patient has no compartment syndrome at present, because there's always the possibility of an evolving compartment syndrome. It's a big problem because there's a massive burden both to the patient and the community, because once we miss it, there are multiple trips back and forth, with loss of limb function. If you've got any questions on this, please free to use the chat box. And Amer, do you have anything further to add on this topic before we jump into our second case?
Can I ask you a question? I just want to ask you a question about, according to the paper by Margaret McQueen, looking at 25 patients. Now, you said that half of them were monitored continuously and half of them were monitored intermittently. How did they go about monitoring them continuously? Because this is the problem that most of us have.
Yeah.
Because
so they've not actually specified their protocol of how. They've just said it's monitored continuously. But from my experience with the pediatric group in Alderhay in Liverpool, they tend to stick a monitor in. They've got a device where they stick it in and they attach it with plaster, so it stays, perpendicular to the limb. And they have. It is a bit of a fiddle because you can lose the monitoring and it starts alarming, and you have to go back and just adjust. But it's usually used in children who have had a block given to them, and they don't want to miss the compartment syndrome post multi-level surgery and application of frames and things to that effect.
Yeah, I think another alternative is to use an arterial monitor. So the anaesthetist will be able to connect a catheter to the arterial monitor. So instead of measuring the arterial pressure, it can measure the compartment pressure, and that's very sensitive as well. I think that's really the key from that paper, isn't it? That if you measure them continuously, you can see the trend. So you can see that if the pressure's going up, that's what should ring the panic bells.
Absolutely, yes, that's a good point. Okay, do you want to talk us through this case now?
Okay, so this is our second case, and this is a 26-year-old man, and he's been playing football, he's been tackled, and he's gone over on his leg, and he's got this spiral fracture of his tibia and fibula. So let's ask the question. Spiral fractures, they're low energy injuries, and we always think of compartment syndrome as occurring with a high energy injury. Can you get compartment syndrome with a spiral fracture?
So compartment syndrome does not occur with spiral fractures. So we've got the majority of the audience seems to have gone with false. So yes, it does occur with spiral fractures. That's the right answer, isn't it?
Yes, yes. So I think the key thing is that in older people, their amount of space within the compartments compared to the volume of their muscle mass means that there's a lot more laxity. But in younger men, the ratio of the muscle volume compared to the compartment volume is really high. So it doesn't take very much for a young muscular man to get compartment syndrome from a relatively low energy injury like this. So I think that was the point that I thought would be worth making with this.
Sure.
So let's
just staying with that point. With
right.
regards where in a tibial fracture, which level of fracture has the highest risk of compartment syndrome? As you say, mid-diaphyseal fractures have a much higher risk because there's more muscle mass there compared to a distal third fracture. Because we hardly ever see compartment syndrome with a distal third fracture, do we?
That's right. I mean, it's theoretically possible, but it's very rare.
Very rare. Yeah. Okay.
Okay. So the next question is, he needs more and more morphine, and the pain is not being controlled by his pain. So the question is, what should we do? Should we release the plaster and reassess him, or should we just say, no, he's got compartment syndrome, let's decompress him now?
Okay, so this is actually on face value, this question is pretty straightforward. Do you go ahead and decompress, or do you release and reassess? Almost everyone seems to go with the option one, which is release the plaster down to skin and reassess, which is the algorithm we discussed. Now, if we just look at that in a bit more detail, Amer, let's say we've released the plaster down to skin, so don't leave even a small film of cotton on that skin, and you don't elevate the limb, you give them some analgesia. At what point do you come back and reassess this patient? And how frequently do you reassess this patient? Or is there ever an instance where you see the foot and you say, no, we've got to go. Let's not reassess. Let's just go and decompress now.
I would say, in a situation like this, like you, I would be feeling very, very nervous, and I'd be going back at least every 30 minutes to reassess the patient. And if their symptoms were getting worse, I would actually check for the first web space, because that's something that's often a subtle sign that there's compartment syndrome there, because as you said before, the anterolateral compartment is the compartment that develops compartment syndrome the most frequently, and the deep peroneal nerve, if that's being put under pressure in the anterior compartment, then the first web space may be where I can feel be able to detect the compartment syndrome first. So I'd be using all these different methods of assessment to try to come to a decision. But as I said before, I'd still feel pretty nervous about it.
Okay, we've got a question from Amer. Can you please re-explain why not elevating the leg is better?
Okay, so Raheel's talked to you about the concept of delta P. So delta P is the difference between the pressure in your compartment and the pressure in your of your diastolic blood pressure.
So the diastolic blood pressure minus the intracompartmental pressure.
Yeah. So if you've got somebody whose diastolic pressure is 80 and your compartment pressure is 25, then delta P is quite large, and so you may be loath to decompress them. But if you've got somebody who has, for some reason, either because they've been losing blood or for any other reason, they might have a low blood pressure, and their diastolic pressure is only 50, and you have a compartment pressure of 25, now delta P is less than 30, and so they have got a compartment syndrome which is threatening their limb. Now, if you elevate the limb, you're actually going to decrease the blood pressure within that leg, and so there's a risk that you're going to lower their diastolic pressure and bring it closer to less than 30 from the compartment pressure. Whereas if you keep it level, then you'll not increase the diastolic blood pressure, so it may be that much further away from the compartment pressure. Does that make sense? Ayman,
say I. Okay, ice compression and its help to decrease. Great, so Ayman's got that. So Amer is asking us about ice compression, its help to decrease compartment pressure. That's a good one. So what does ice essentially do? It vasoconstricts.
Would you use ice as a means of combating the risk of compartment pressure?
So I've actually never used it, to be honest. I can see it makes sense, but I've never used a bag of ice or frozen peas or things like to that effect to reduce compartment pressure.
That even if you use it, the problem is that when you then take the ice away, you get a reactive hyperemia. So actually, it may work temporarily, but then when you take it away again, because you can't leave it on forever, it may then cause a reactive hyperemia and make things worse again. So
it's an interesting point, Amer.
Like yeah, I've never used ice for that reason.
Yeah. So when it comes down to diagnosing and taking a patient to theatre, Amer, have you at any point in time taken down this dressing, had a look and said, we need to go now? Or do you always tend to just hold back for a bit, reassess the patient? What's your usual go-to? I know it varies patient to patient, but let's say you see a patient, it looks firm, it looks woody, he's got passive stretch. Would you still give them some analgesia and just because the snapshot view you're having and come back in 20 minutes?
I think that if all the various factors if they're woody and swollen and got pain and passive stretching, then there's no point in waiting to reassess. You've made your diagnosis and you've got to decompress them as soon as possible.
Great. I think that's the take-home
you know,
message. So
the
yes,
point
the
of this question is that if you release the plaster and things get better, or those symptoms, those other factors are not present, then you should wait and reassess. But if you've got enough evidence that they've got compartment syndrome, I think you've just got to go for it. Okay, so let's move on to the next slide. So the pain seems to settle, but then you notice that there's altered sensation in the first web space. What are we going to do? So let's ask the audience again.
So bearing in mind that you've got a high, we've discussed in the talk, there's 40% infection rates with fasciotomies, you've got all these other complications. Would you go ahead and decompress or would you observe? I think I'm swinging the vote there.
I think this is a difficult question to answer, and you know, you will find that there will be lots of experienced people who will have different ideas about this. So there's no one definite right or wrong. I think, as you said before, you've just got to document what you found and reasoning for making your decision. What would you do if they've got altered sensation in the first web space? What would that make you worry about?
So that, as we've discussed, is one of the earliest signs of compartment. So obviously this patient has a compartment syndrome. He or she is probably on that on balance. We don't know which way they're going to swing. If the pain is better, I certainly would just wait and observe. I wouldn't dive in. But at the first hint that they're sort of deteriorating, I would take the patient to theatre.
Yeah. So really, it's a dynamic situation, isn't it? You can't just make a decision and forget about it. You can't make a decision and go home. You've got to make a decision for that moment, and then 30 minutes later, have a look again and reassess. And only if it's continuously pointing towards it not being compartment syndrome would you leave them. But any suggestion that it's compartment syndrome, you're going to decompress. So it's interesting that most people say that they would continue to observe. So that's of the people who've answered, 82% have said that they would observe, and 2 people have said that they would decompress. And I would say that actually there is no right answer. And if you decompress, no, I don't think anyone would criticize you. If you continue to observe, you've committed yourself to reassessing them again, within 30 minutes.
Yeah. Okay.
So now, this is the type of picture that you don't want to see. So this is one of my patients, and the fasciotomy have been performed, and underneath there is dead muscle. And it's one of the most heartbreaking times as a surgeon when you open up someone's leg, especially someone who's young, and the muscle is dead underneath. And the question is, what are we going to do with that dead muscle? We're going to close the wound up and treat it like you might do in the foot and just let it die and try and deal with the consequences afterwards? Or are you going to debride that dead muscle and take away that dead muscle? Or are you going to say, well, this leg is really beyond salvage and they need to have an amputation? So what would you do, Raheel, in a situation where you've got dead muscle?
So this is a tricky one, Amer, but I actually think it comes down to whether this patient has a fracture underneath or not, because it's going to change what I do tremendously then. Because if there is a fracture, then there's no doubt you've got to debride all the dead tissue there. But if there is no fracture and this is a soft tissue injury which has contributed to compartment syndrome or a vascular injury, then the gut instinct is to debride all muscle. I know there is a school of thought that you leave and let it scar up and fibrose. So it's a tricky one. I would hope there's a fracture because then it makes my life easy.
Yeah, I agree. You know, again, you know, there isn't definitely a right answer. You've got dead muscle, and once you've opened them up, you know, your concern is that if you've got dead muscle, that's going to become infected.
I think
it's certainly going to be
the answer to go away with, particularly for the exams, is that debride it, because you don't want to open yourself up to controversy. Because once you leave muscle which is dead in, you're causing rhabdomyolysis, you're causing renal complications. So the easy and the safe thing to do would be to debride all muscle. We don't want to get into controversies wherein you leave stuff in as soft tissue to scar up. Would you agree with that?
Absolutely, and also if you've got necrotic tissue, that, you know, it's basically a possible focus for infection. So you've got to debride until you get back to bleeding healthy tissue again. And unfortunately, that might be that you have to empty the whole compartment, but that's what's necessary in this situation. You know, and so at some point in your career, in everyone's career, they will come across a missed compartment syndrome, and they will need to make this decision. And it's very difficult. What I think is really useful is to speak to colleagues and to actually have several people there in the operating theatre. So if I was to come across this situation, I wouldn't make a decision on my own. I would be ringing up Raheel, or I would be ringing up my other colleagues and saying, I'd like you to come, have a look, and let's share the decision making and share the responsibility, and make it rational. Because in this situation, it's very easy to become emotional and to overthink things. And sometimes you need someone from the outside, a fresh pair of eyes, or you know, sound ahead, to come and sort of talk sense. So it's always useful to have colleagues come and join you in the theatre in this situation and sort of make a joint decision.
Absolutely. I'm just sharing a question with the audience. I'd like you to answer. While we're doing that, Amer, do you want to summarize some key take-home principles for the talk?
Okay, so I think Raheel has given you a really succinct, you know, and well-honed talk on compartment syndrome. I'm hoping that what you're going to take home is a good idea of what compartment syndrome is, what causes it, and how you've got a simple algorithm to follow, which is going to give you a way of making decisions which are defensible and rational, and also, you know, showing you where your responsibility lies. And Raheel's also talked to you about the lower limb fasciotomies, how to make them, and given you some sort of key surgical tips. And I think, you know, the other thing that people should take home is that this isn't an easy situation, and you shouldn't always have to make these decisions on your own, and share the responsibility, so that you know that you're making the right decision for that patient at that time.
Thanks, Amer. That's well put, I think. We asked the question, how many of the audience have done a decompression as a primary surgeon? And hopefully that answer there, even if you've not done it as a primary surgeon, you've got some key take-home tips on how to decompress the 4 compartments of the leg. And that we're going to also push to you a link, which I'd like to share with you on. This is actually on the one controversial thing we discussed. It's coming up on your chat icon. It's the controversies with foot compartment syndrome. It's a short read. It's a nice read. Have a look at it. It's all evidence-based. You can download that PDF through the chat, and hopefully that will give you some additional things to mull over as well. Amer, anything else? Any questions from the audience? Please do share. Omer has something. I'm sorry to bother you. How to deal with a neglected patient more than 24 hours? Are you treating them with medical treatment or start a decompression? Okay, so I think this is an interesting one before we round up. How do you deal with a missed compartment syndrome when you 24 hours down the line? So this patient's developed compartment syndrome and now you're looking at him the next day.
I think that 24 hours is a difficult time because I still think at 24 hours there's a role for fasciotomy. But you know, if you get to say, if you think that you've missed a compartment syndrome by 72 hours, then you know it's more controversial about going in there and debriding because you've already missed the boat, and all the complications that were going to happen, you know, already occurred. You know that you've got that muscle death. 24 hours. I still think there's a role for fasciotomy because you may have still viable tissue which you can salvage from becoming necrotic and ischemic. There is no clear timetable. You know, there is no right and wrong answer for this. But in my experience, at 24 hours, you know, there's still room there for salvage. At 72 hours, you know, really, it's too late. What do you think, Raheel?
I think I agree with you, Amer. As long as the patient's still feeling pain, we've not missed the boat. Yeah. So I hope you found that topic and talk useful. We've just uploaded something for you to download. Feel free to do so. It's a bit of additional reading material. Next week, we're going to be discussing damage control orthopedics, which is an interesting topic. And hopefully we'll meet again. And the following month, we're going to be having, the theme is going to be foot and ankle. And we'll take it, we'll send across flyers as to topics we're going to be dealing with. Any final questions before we round up? Excellent. Amer, thank you very much once again. Look forward to seeing you next week.
Thank you, Raheel, and I look forward to seeing you for the damage control next week. Take care. Bye-bye.